Now I'd like to invite you both to join us for a panel discussion. We have quite a lot of questions and 24, 25 minutes to answer them. So let's get to it. The first one that's been voted up comes from Panberry, and it reads, just wondering, is there any research on women who have had vaginal birth in their home country, but then end up having an emergency cesarean section in Australia? If so, is it because of fear and less oxytocin now they are in a new country, or from better diet, bigger babies?
Oh, thank you for that question. Look, I'm not 100% sure if there's research, but certainly if you think about all the things that, you know, language, support mechanisms, friends, family, if they're missing all of those things and go into labour, if they've had a baby before, they're more likely to be able to labour and birth. But certainly you would see some of the same things play out for women in that case, you know, but it's, you know, once they've had a baby, they're at least a little bit lucky that their body might get on and they don't, you know, labour and birth better than if they were a primate, but they still need the love and support and all of the things that go to make that birth experience important and for them, you know, the centre of the baby.
And please feel free to comment, and that goes to both of you. So Naila, if you have any comments on that question, just feel free.
I think that you answered it really well, Jennifer. Thank you.
Thank you. So we'll go to the next question by Pari J. Are social workers included as part of the team approach to care, both pre and post birth at the maternity level? And she thanks you for an excellent presentation.
Oh, thank you. Look, I mean, I think every service is different. I think some maternity services really struggle and they don't have any social work support. I think it's a fundamental part of what we should be doing and working together, and we all have different roles to play. So we're lucky enough in the health service that I'm currently working in. We could always do it with a little bit more, but we certainly rely on our allied health professionals quite a lot, and hopefully we demonstrate those good working behaviours and learning from each other. You know, we've all got something to offer and learn from.
Thank you.
Thank you.
Naila, did you?
No, thank you, Jennifer. I just wish that a lot of our clients also had some of those facilities. It's really like I described. They really struggle.
Yeah.
Yeah, there's such a lack of control. And there was some of the things that you mentioned with the birth interventions, like must have someone with them, you talked about. They must be able to eat and drink. They must be able to move freely, which is something that our clients don't really have the opportunity for.
Look, and I think it's not long ago that I've just been involved with a family that came from, it's just the name's gone out of my head, but no support, an older couple, no family, nothing around them, and they came into the birth. I don't think we meant to, but I don't think we got the right interpreters, or we didn't get enough interpreters for them. They weren't used to our long, you know, our terribly long waits in some of the antenatal clinics. So that was really distressing for the partner, and he was angry about that and didn't understand that, and they put a complaint in and they didn't get an answer, or they didn't feel like they were validated. And then of course they go into labour, and the whole thing just goes from, she did actually really, really well, but ended up with an emergency cesarean section. And so this whole picture of what we've just talked about played out down the track. But what was really, when I went and did a session, the social workers, I did it with them, but they also had a real lack of knowledge about just birth. So some of what was playing into their trauma was they just didn't know how the body worked or what the processes were. So that's not their fault either, but you know, that inability for us to really connect with them on a level meant, you know, they were really let down. And I think after the session, the partner was more understanding, but the woman was wanting an answer. She wanted it fixed. And of course we couldn't fix it. you know, she just, and so trying to work and say, look, it's a healing process. We've got to do, I don't know if you find that sometimes, but she wanted an answer to why she was feeling so emotionally distressed. And I couldn't give her, you know, other than I couldn't make it go away. And she wanted me to make it go away. And I couldn't, you know, and so, you know, so it was really distressing to realize just how poorly our system had let her down, you know, a whole lot of things.
Yeah. I think deliveries are even more difficult when our clients are in detention.
Oh, yeah.
And
Well, you know, how can you labour? Like, I mean, no one, you know, you know, I've had 3 babies myself, but I just can't imagine what it must be like, you know, that isolation, the loneliness, the control, the fear someone might do something to you, the violation of your body, you know, like you've talked about, all of those things, you know, coming back. You know, we know vaginal examinations are a real trauma for sexual, and if we've not, it's if you can deal with that and put it on the table beforehand, then you've got some ability to start to work with it. But if you can't, if you haven't, then that woman's just completely left to her own devices. And you know, of course, she disassociates, she doesn't remember what's gone on, she, you know, it's you know, it's a real issue that we have to get our head around and have to pay attention to. And unfortunately, you know, women don't rate women's welfare doesn't rate that highly sometimes on the agenda.
I certainly couldn't think of a worse environment than a detention, particularly immigration detention environment, which is like a limbo for these.
Just shouldn't even be there in the first place. Like, you know, that's what's so just soul destroying, is that, you know, I can't even believe as Australians we would even do that.
I have found that the mothers are not in touch with their own intuition because they've been through so much trauma.
Yeah.
You know, they don't know when they got pregnant. It wasn't a planned pregnancy. It's not like they plan anything in their lives. They just, and when you were talking about when did I give birth, you know, and I thought they probably just don't know when they got pregnant, when they gave birth. And now having to look after the baby, they're not able to breastfeed because when there's a lot of trauma, as you know, even the babies are not ready to breastfeed. So yeah, it's a difficult situation.
Yeah, absolutely.
I take you to the next question, which is how can people of cold background access prenatal orienting tools for preparing for birth?
Nala, do you have, I mean, most health services do have information that's transcribed into different languages, but reading a piece of paper isn't, you know, often going to give you the intimacy and the nuances and, you know, the ability to really talk through and deal with and put on the table. And you need a relationship with someone. So, you know, if you come into a service and you don't see the same person every time, and you see 50 million different people and you wait and this doctor and that, and you're repeating your story, why would you say anything? You know, it's no wonder women go, what? I mean, this particular couple that I talked about, they were from Bangladesh. They even at one stage said they didn't want the interpreter. And I wonder whether that's because we weren't actually able to connect with them in a way that allowed them to use that, you know, even allow them to connect with themselves. And it was also an IVF pregnancy. So you wonder whether, again, feelings of body failure, what, you know, all of that playing into it, whether we actually ever, you know, worked with that.
Thank you. The next question actually takes us back to what we were discussing before. It comes from Katie Pickett, and it reads, how do you think trauma on the refugee journey can affect the development of babies before birth? Could this lead to a baby being stillborn?
Nala, did you want to make a comment about other effects or?
I'm not sure about that, actually.
Okay, so certainly, for instance, what I can share with you, if you look at the research around continuity of midwifery care, and providing a woman with her own midwife, regardless of whether she's high risk. There's a 24% decreased risk of stillbirth. So something in that support mechanism and that love and that relationship that she has with her midwife that follows her through is doing something to protect her and her baby. There's also less preterm birth. So again, it comes back and starts to speak to support, someone knowing me. I've got a relationship with someone cares about me. So, you know, it's hard for some people to even grasp that because they want black and white, but that's fundamental. So if we can get those kinds of differences in things like, we've been spending millions of dollars on trying to prevent preterm birth. Well, we just need to reorientate our maternity services and we might be able to decrease it quite substantially. But you've got to have a commitment to go to a social model of healthcare. And of course, what is our healthcare is set up around acute care funding. And, you know, there has to be a commitment to make it primary led in the community, close to women's homes, the things that really matter to how women live their lives with their families. So I hope that might answer the question. So that question probably is, yes, there are some things we can do, but it's around support, the biggest predictor of what happens.
Thank you. Our next question reads, is it safe? It comes from Julie and it reads, is it safe though for women to speak up during care? What psychological safety measures are there that they won't be victimized for speaking up?
Yeah, look, that's a great question, Julia. I absolutely hear where you're coming from. And I guess that comes back to, we have to reform and change how we do business. We need, you know, mainstream reform to our mainstream services so that women have relationships, because like I've just said, relationships save lives. So we need to set women up so they have the same people that they talk to. And women they should speak up, but of course they are, you know, there are people that, you know, are rude and don't listen. And, you know, there's no guarantees, but that's why we have to get messages to women about, how do you want to do your pregnancy? Who do you need to be there? What are your options? Who's going to be with you? You know, and again, that's why as a system, we need to reform the system and not put it back on women all the time. You know, it's, you know, we need to do something as a society and a system to make sure they shouldn't have to be worried about, you know, you shouldn't have to be worried about being treated poorly, you know, like, you know, but we need to value that. And I guess that's where refugees, do we really value that? Probably not. That's why we've got policies like we do. Do we really value women and their babies? You'd have to argue, I wonder. You know, what are the things that drive some of our social policies?
Naila, would you like to comment on that from your experience working with clients that have given birth in Australia?
I think the best that I can do, because I don't really see them when they're giving birth, unless you know, like in Sarah's case, mum was pregnant. I think the most important thing for me is that the mother feels good as a parent. She feels good about herself, and I think perhaps that would make it easier for her to know that she's, you know, she's pregnant, and she'll be able to look after her child well. Other than that, I don't really give a lot of advice before a baby's born.
I think from my perspective, what's important about sessions like this, and I felt really nervous doing it because I thought I wouldn't be able to offer you anything, but I think just all of us in all the different professions knowing how important birth is, and then being able to say to women, okay, I don't know a lot about this, but I do know that you need A, B, and C. Why don't we see if we can find out what your options are in your local, you know, everyone saying to women, what are the options? Where else can you go? What other things can we put in place for you? You know, really start to challenge as services. Okay, what does our local service offer women? How can we improve it? You know, where's the continuity? Where's the continuity model for this woman? How can she have her own midwife? You know, that kind of demand.
That would be incredible if we could have midwives for our clients.
Yeah, you know, you should.
Yeah.
They
Or
should be
doulas.
working. Yeah.
Yeah, I think doulas would be just great for them, especially because they don't have their parents. And I'm really surprised at how often a mother will come and say, I don't know what to do with my baby. I don't know what to do with my children because I don't have my mother here. Or, yeah.
No, and certainly, Jennifer, your perspective is most important to us, and that's where I think, you know, trauma informed care, you know, it's important. We need to learn about how trauma can impact on different areas of people's lives, both pre-existing trauma and some of, you know, traumatic events that might happen after. In a way, that brings us to the next question by Caroline, and how would someone from psychotherapy mental health support profession refer to a midwife prime type program? Jennifer?
How would you refer?
Yes.
Look, I think that's about the conversation, saying, you know, I heard this presentation. What does my local, you know, what does my local health service offer? And, you know, the question is, do you, you know, I want, the question you ask the health service is, how does my client get their own midwife? Or do you have a continuity model so she gets her own midwife? You know, so lots of services have them, but they're just often full. And this is where, you know, the work has to scale up so that we offer it. It's the standard model, but that's where we're struggling. We're struggling with all the things that health services and bureaucracies, funding models. You know, it's not hard to do if you could just get everybody else out of the way and just say, right, but you know, there's so many different layers. But in terms of other healthcare professionals, it's about asking the question, what's in my local district? Have they got a continuity model? How can I access for my client? Going to health services and saying, we want to work with you. Can we have a midwifery model join our team?
Thank you. And we've got a couple of really interesting questions coming up. First one is from Catherine Theodore. And the question reads, for some women, postnatal depression sometimes could be more accurately captured by postnatal depletion. See Dr. Oscar Seralak. Yeah. How could postnatal follow-up care with GPs and midwives better address adequate supplementation, nutrition, etc. for the mother? In your experience, is this commonly screened for, not only psychometric questionnaires such as Edinburgh Postnatal Depression Scale, but at a physiological level, such as through blood hormone level 6 months postpartum?
Is that for me or, yep?
I think it's for either, but I think, Jennifer, you might want to go first on this one.
So, I should have written that down. I should have, because now I've had a bit of a mental blank. I think it's about support postnatally. Was that the question? Sorry.
Yes, I think Catherine, you know, quotes Oscar Seralak.
Okay, that's
in that postnatal depletion, and asks whether, you know, there's anything, you know, about nutrients. Do we monitor this at all, and how can we?
I don't think we do a holistic approach. I think there is, Leslie Barclay many years ago talked about the misery of motherhood as opposed to, you know, the label of postnatal depression. And I guess coming back to Catherine's point around communities and where are women in their communities, what support mechanisms that they, because we've had such a hospital-based system that if we could transition to kind of social models of health, then those kinds of things we could address. You know, midwives should be visiting. That's not that child health's not important, but from the models that I come from, you provide postnatal care up to 6 weeks, and then you hand over to child and family health. I think about the difference that makes in terms of, you know, visiting women, talking about nutrition, talking about siblings, talking about partners, and then helping them transition to their community care. But I think Catherine's like, we don't do it well. We have a kind of very, okay, you've had the baby, go home, get sorted. And, you know, we don't often talk about things like the red tent. You know, women should be 40 days and 40 nights clustered with their baby and their family, being fed and given the right nutrition and helped to heal after birth. But we've kind of got this very individualistic, okay, come on, you better get up, you better go to the supermarket, you better start, you know, operating on a level that says, this is what we expect of you. When really we should be saying, you need to be in your red tent for the next 40 days and 40 nights, and everything, your food given to you, love given to you, so you can be with your baby, so you'll never get this baby again. You might have another one, so that you can learn to breastfeed, learn their cues, sing to them, all the things that help a baby attached to the breast. Yeah. I hope that's answered it, Catherine.
So the culture that our clients come from definitely have that red tent. I like the way you described that. And it's like a fourth trimester, that those 40 days, or maybe 3 months sometimes, where the mother comes to look after. And the case that I've described, the Sri Lankan family, I remember the mother had mentioned that on the 7th day, they have a feast when they name the child. You know, they miss all of that.
And I think that's so difficult for them. This family, Bangladeshi family, you know, she also talked about not having those traditions and cultures, and then people, they had no one around them, you know, like just no one, you know, and then struggling with a really difficult birth and not understanding, and you know, it just each thing just built on the other.
That's right. Thank you.
Thank you. We're getting close to the end of our session, but there's a couple of questions that it'd be great to be able to address. The first one comes from Sitota Kian, and it reads, Naila, how do you balance supporting the mother and child without taking over her role, the mother's role?
That is such an important question. And that's something I'm very, very, very conscious about. So really, right from the beginning, I make sure that I notice things that the mother does well, and I empower her, and I include her during our play therapy session. So it's not just me and the child. Generally, play therapy is with the child alone, but we encourage the mothers to come in and get involved. That's how we handle it. Yeah.
Thank you. Jennifer, would you like to comment on that from your experiences?
I mean, I haven't been in that therapy with children, you know, children, but certainly as a woman, as a midwife going to visit in the home environment, you do watch across pregnancy how people interact, and you talk about sibling behaviour. So, you know, as a midwife, I'm there for the woman, but certainly, you know, making sure I balance that role and not overstep them up, but also potentially sometimes opening up and having that relationship where we can perhaps start to talk about what that looks like for her, and she feels comfortable to verbalize how things are going for her, and then you've got some ability to help. You know, you might say, well, have you thought about this? Maybe that would be good. I could explore that for you. How about I go away and find that out, and I'll bring it back next time. So, you know, you might, let's talk about whether you might need that. But certainly with some of the women have been very traumatized. They've definitely responded to perinatal mental health work, because they're so disconnected from their baby. By the time they do connect to their baby, they've got really poor relationships. And, you know, then they have to spend all this time trying to develop a relationship. And if they do have a better birth, and I work with them and they have a much better birth, then they feel guilty about what they felt. You know, like Naila said, you know, the mother was teary and feeling guilty. And so that can happen with women who have a healing birth, but then they look back on the first birth and they go, oh my God, this was so much better. And then they feel you have to address some of the guilt that can come with now having a better birth, because they can see how the difference in how they're feeling about this baby to how they felt about that baby.
Thank you. The last question we have time to address tonight is not really a question, but a comment. It comes from Glenys Frank, and it reads, my PhD is a maternity experience of women seeking asylum in Australia. I have found few models that provide continuity of care for these women. Frequently, no interpreter or poor interpreting is provided in the birth environment. Before I let Jennifer and Naila comment on this comment, I'd like to invite you, please let us know when your PhD is completed. We would love to
Absolutely.
speak about your findings. So that's a great area to explore. But Jennifer, Naila, over to you. Would you like to comment on this comment?
Like it's a difficult one. So we do try and get interpreters. You know, now of course we have to ring them, book them. You know, so there's certainly those facilities that they're available. But it does mean the healthcare professional has to make sure that they're working and try and, you know, accesses it. And if in pregnancy it hasn't been clear that we need that, then a woman might come to the birth suite, and of course nothing's written anywhere. And so the birth suite, potentially the midwife performs a kind of quick assessment and potentially might not realize just how much the woman doesn't understand. So I wonder sometimes when we're not quite, you know, we think she's understanding because she's nodding or whatever, but she doesn't actually understand. And so we don't then go the next step and say, okay, well, you know, we need an interpreter, let's ring them in, you know, whatever.
Yeah, and that interpreting can be just so important. Yeah, whether it's on the phone or whether, you know, whatever way we can access it. Yeah. Yeah, that's great. I would love to have some contact with Glenys once she's finished her PhD. Yeah, thank you.
So Glenys, a very clear invitation. Keep in contact. We'd love to you know, to read your thesis and
she should
maybe,
present.
yes, maybe invite you for a discussion sometime. You know, once it's completed. It is a really interesting topic. On that note, 3 minutes after 8, I would like to thank our both speakers. It's been a wonderful couple of presentations. I really enjoy them. So interesting, and clearly it's a topic that it's got many facets to it. So I'm sure that it will feature in future masterclasses going forward. So thank you again so much, and I'd like to invite everyone to please look in our website. We are going to have another fantastic program addressing different issues that look at different aspects of our work with people that have survived trauma in the context of organized violence and the refugee experience. So please look it up, and I'd love to see you next year. So I'd like to thank, I can see Nuria, who's in charge of organizing the program. So thank you, Nuria, for a wonderful year of clinical masterclasses. And thanks also to Melanie Limon and Emina Kovac, who's manage and support this program. It's something that I'm really proud of in the work of the STATS. And I look forward to see you all next year at the clinical masterclasses.
Thank you.
Thank you all now, and thank you again for joining us this evening. It's been fantastic.